Well, good morning, everybody, and welcome to the Osher Center for Integrative Medicine Grand Rounds. My name is Peter Wayne, and I serve as the director for the Osher Center. Today, we're privileged to have Dr. Michael Ferguson presenting on the very exciting topic and emerging field of neurospirituality. But before introducing Dr. Ferguson, a few practical matters. First, if you wish to request CMEs, please be on the lookout for a note in the chat feature of Zoom that'll provide some detailed information. And then second, as you listen to Dr. Ferguson's presentation, we encourage you to write questions for him using the Q&A feature. I'll be collating these questions and present some of them to him in the discussion following his lecture. So it's now my pleasure to introduce my colleague, Dr. Michael Ferguson. Dr. Ferguson is Neurospirituality Research Director at the Center for Brain Circuit Therapeutics, which is based at Brigham and Women's Hospital. He's also an instructor in neurology at the Harvard Medical School, a lecturer in neurospirituality at the Harvard Divinity School, and a course co-instructor on the cognitive neuroscience of meditation at Harvard College. Dr. Ferguson earned his PhD in bioengineering at the University of Utah, where he studied religious experience using functional magnetic resonance imaging. He then completed postdoctoral fellowships in cognitive neuroscience at Cornell University and in cognitive neurology at BIDMC here in Boston, before joining the neurology faculty at Brigham and Women's Hospital. As you'll learn firsthand today, Dr. Ferguson mixes his deep insight and curiosity regarding spiritual experiences with rigorous and state-of-the-art brain imaging tools. His work's been published in numerous leading journals, including Brain, Nature Communications, Human Brain Mapping, and Biological Psychiatry. I, for one, am really excited to hear his presentation today. So without further ado, please join me in welcoming Dr. Ferguson.
Thank you so much for that generous introduction. I am really thrilled to be here and so excited to have this opportunity to speak with you about neurospirituality with a little bit of a poetic flourish, which is subtitled Science, Circuit, and Soul. Let me just adjust my screen. There we go. Okay. So as was mentioned, I have affiliations both at Harvard Medical School and Harvard Divinity School, and I have no conflicts of interest to report in association with this presentation here. Right at the Longwood campus, there is a very provocative statement on one of the walls. It's at the Joslin Diabetes Center, and it proposes that the evolution of medicine is in reality the history of man and his religion. Okay, and then it goes on to actually give examples across culture and across time to support this proposition. Today, however, of course, we live in a situation where health sciences and spirituality have this effectual wall that's been built right down the middle of them. And of course, there are a lot of historical reasons for this, which I'm happy to discuss. But it does beg the question about whether this is an optimal relationship between health sciences and spirituality. And this is a type of question that this emerging field of neurospirituality seeks to address. What is neurospirituality? Well, most basically, the prefix neuro, of course, refers to the brain. And spirituality, I really am fond of a definition for spirituality that comes from the Oxford Handbook of Positive Psychology, where it defines spirituality as a search for the sacred. Again, there's a lot that I could comment on with regard to this definition. Briefly, I'll state that the flexibility of this definition, as well as its concision, are very valuable. This can incorporate non-theistic or theistic concepts of spirituality, fundamental or emergent concepts, essential or constructed concepts as well. And so putting these together, though, neurospirituality then is the study of the brain's engagement with the search for the sacred. Why should one study spirituality scientifically? Well, here's a couple of reasons. Spirituality remains a pervasive cultural fact in societies across the globe. And, particularly in the United States, 92% of Americans report believing in a God or a universal spirit. And up to 65% report to pray daily or weekly, even outside of religious services. Empirical studies have also linked various elements of spirituality, both to adaptive and maladaptive aspects of human functioning. And I think that it might be important actually to underscore the maladaptive component of this, lest we get, a distorted view of the nature of spirituality. clients and patients themselves also are interested in therapeutic approaches that are both spiritually sensitive and integrative. And then lastly, for now, note that the American Psychological Association has defined religiousness as a cultural diversity variable, and a primary function of religious institutions is to promote spirituality. Okay. All right, even though health sciences and spirituality have largely been segregated in the last century, there are growing efforts to integrate them in an evidence-based fashion. And notably here within the Harvard medical ecosystem, Dr. David Rosmarin is working on spirituality integrated in psychotherapy and demonstrating that there are benefits across a wide range of indications and diverse levels of acuity for spirituality integrated into psychotherapy. You may have seen his Scientific American article where he doesn't pull punches, and he titles it "Psychiatry Needs to Get Right with God," and then proceeds to make arguments for why, again, we ought to really reconsider the roles that spirituality and religion can play in a therapeutic setting. One of my questions is whether we can introduce a higher degree of precision to this integration of health sciences and spirituality. And in particular, I'm really curious what could happen if we apply brain circuit methods to spiritual phenotypes. A few of the methods that are typically used include task-based fMRI. And this is a method that I was trained on in graduate school, where I used task-based fMRI to look at neural correlates when Mormons or Latter-day Saints were engaged in religious tasks. So things like prayer, engagement with scriptures. And I speak about some of these findings in my TEDx talk titled "This is Your Brain on God," which I'll invite you to check out if that's a curiosity for you. Here, though, at Brigham and Women's Hospital, I've been helping to develop an emerging technique called lesion network mapping. And allow me to explain a little bit about the methodology for lesion network mapping. Brain lesions, as is well understood, are a causal source of data about cognition and behavior. What can happen, though, is that you could have multiple patients. So here's a cartoon diagram showing 3 patients who all have brain lesions in different locations, but they all present with the same symptom. So that can lead to an unclear localization for a particular symptom. One of the insights that we leverage is that the human connectome can give us a unified understanding of brain lesions that occur in distinct locations, but are all associated with a common symptom. And this is where the network part of lesion network mapping comes into play. To do lesion network mapping, we can either use anatomical connectivity diagrams of the human brain or functional connectivity diagrams. So here's an example of a study that we performed looking at brain lesions that caused amnesia. Here's an example of 10 out of 53 patients who all presented with brain lesions in different areas of the brain, but all of which caused severe amnesia. The first step then is to take those brain lesions and to convert them into a whole brain connectivity map. This we did using the functional connectome. Once we then identify the whole brain connectivity pattern for a given lesion, we can overlap that set of lesions that are causing a similar symptom and identify the core areas where there's a convergent overlap across all of the patients. And in this particular study, we identified a region in the subiculum going into the retrosplenial cortex that accounted for over 95% of the brain lesion networks that were causing severe amnesia. And this overlapping region was both sensitive, again, meaning that it encompassed over 95% of the lesion networks from these patients, and also specific. So when we compared it to other symptom-causing lesions, we did not see the same convergence pattern in this area. More recently, I've applied the same technique of lesion network mapping to look at behaviors associated with spirituality and religiosity. And this is work that was just published in the journal Biological Psychiatry. Just doing a quick logical breakdown here. We can have an overlap of spiritual and religious behavior. We can also have, though, spiritual but not religious identity or behavior, and then also religious but not spiritual identity and behavior. And in this study, we were looking at the union of what constitutes both spiritual and religious underpinnings at the level of brain circuits. For measures of religiosity, patients were simply asked, do you consider yourself to be a religious person? And for measures of spirituality, we used a psychometric from the temperament and character inventory, which is termed spiritual acceptance. And scientifically defined, spiritual acceptance indicates a stable worldview, which includes forces that cannot be rationally comprehended or objectively proven. Some people ask, well, so belief or faith? And yeah, that gets to a just understanding of what it is that we're capturing with this spiritual acceptance inventory. Here are a couple of example items so you can get a flavor for the types of questions that are involved in measuring spiritual acceptance. They include, sometimes I have felt my life was being directed by a spiritual force greater than any human being. I think that most things that are called miracles are just chance, and that gets reverse scored. And also, religious experiences have helped me understand the real purpose of my life. Now, this was just a wonderful data set for this type of study because we were looking at neurosurgical lesions. Neurosurgical lesions, unlike, for example, stroke lesions, allow us to temporally anticipate the onset of the lesion. In other words, we can do longitudinal behavioral assessment. So before individuals go in for surgery, we can measure a trait like spiritual acceptance. They'll have their surgery, and then afterward, we can once again measure the same behaviors or acquire self-reports of the same sets of behavioral traits. And that allows us to look at any changes in those measures that we can then infer related in some way to the lesion itself. This top row here is a depiction of 4 of the lesions that cause the greatest decreases in self-reports of spiritual acceptance. And this bottom row here indicates the locations for the 4 neurosurgical lesions that were associated with the greatest increases in self-reports of spiritual acceptance following surgery. And this was a data set of 88 neurosurgical patients. The main take-home message here is that once again, you can see that these lesions don't all simply localize to a singular area, that they're heterogeneously distributed across the brain, which makes it a perfect match for our lesion network mapping techniques. So we take our 88 neurosurgical lesions, apply the human connectome to identify a whole brain functional connectivity pattern relative to these lesion locations, look at the changes in these self-report measures of spirituality, and then on a voxel by voxel basis across these 88 individuals, do statistical comparisons to see which voxels are associated with changes in these self-report measures of spirituality. And in our discovery data set, we found a peak location in the periaqueductal gray that was associated with changes in spirituality. This was not where I would have guessed we would see an association with changes in spirituality. And so we did a lot of validation to test out this result. If we then look at whole brain connectivity relative to the periaqueductal gray, what this means is that we would predict that brain lesions that damage the areas that have a positive functional association with the periaqueductal gray would correspond to a decrease in spirituality. And in the opposite direction, we would predict that brain lesions that were associated with areas that are anti-correlated, or in other words, negatively correlated functionally with the periaqueductal gray, would cause an increase in spirituality. I'm happy also to talk more in the discussion period following this formal presentation about the push-pull model of functional dynamics in the brain, such that if you have a disinhibition of the periaqueductal gray, we would expect that to be an increase of function in periaqueductal gray circuits, again, in this context, associated with an increase in spirituality. All right, so there's a picture once again. We tested this in an independent data set of brain lesions for which we had religiosity data, and did a 2-sample t-test looking at the quantified network damage score for lesion damage to the periaqueductal ray circuits, comparing individuals who report to be non-religious with individuals who report to be religious. And so when we look again statistically at these quantified values of network damage to the periaqueductal ray circuit, we get a statistically significant separation between the non-religious identified and the religious identified individuals on the basis of brain lesion damage to periaqueductal gray functional circuitry. All right, so now I went back to square one and I flipped the discovery and the validation data sets. And so now starting completely from scratch, I was looking at the voxel-wise associations with differences in brain lesion networks for individuals who report to be religious versus individuals who report to be non-religious. And in this independent discovery process, once again, I identified a peak association between religious versus non-religious identification based on lesion connectivity to the periaqueductal gray. Flipping now the validation data set here, I identified a statistically significant correlation between the amount of damage to this periaqueductal gray circuit and the continuous change in self-reports of spirituality after neurosurgery. So just to recapitulate here, I have a cross-validation where in two independent discovery processes, we identify a peak association between brain lesion network connectivity with the periaqueductal gray on the basis of spirituality or religiosity. And in a cross-validation manner, identify significant predictive value for religiosity or spirituality on the basis of brain lesion damage to the functional circuits defined by connectivity to the periaqueductal gray. One of the technical issues that comes up a lot with functional connectivity is this issue that's been termed global signal regression. And in short, it's a concern that perhaps some of the connectivity strengths with regard to positive or negative signs or the magnitude of positive or negative correlations might be at least in part driven by the global signal, which can include respiratory artifacts or cardiac artifacts. And so again, went all the way back to square one, used a connectome that was derived without global signal regression. So here now, I did 4 different passes through this workflow: global signal regression connectome for spirituality and religiosity, and connectome without global signal regression for spirituality and for religiosity data sets. And in each of these 4 analyses, I identified that the top voxel-wise associations were all in the periaqueductal gray. To further seek validation of this hypothesis, I looked for case reports that were associated with hyperreligiosity and identified in previously published literature 4 different case reports where there was a brain lesion and an image of the brain lesion that was associated with patient onset of hyperreligiosity. And by hyperreligiosity, we really mean something that was disruptive of typical function. So for example, a spouse who was concerned that their significant other had joined 4 different religious movements in a single month. So something that is well above what would be considered typical religious behavior here. And in each of these 4 cases, the brain lesion damage was located in this negative correlation zone relative to the periaqueductal gray, which again fits in with this hypothetical model of damaging the inhibitory brain networks, which we would anticipate to cause a release effect or anticipate to facilitate hyperactivity in the functional circuitry associated with the periaqueductal gray. All right, now the last analysis that I did here was to look at the alignment of brain lesions. Oops, I lied. I have another analysis for you. Sorry. Okay. So quick art history interjection here in the interim. this is a depiction of Teresa of Avila, who is a 16th century mystic who is believed to have experienced epilepsy. And there is a long-standing association of epilepsy and seizure with hyperreligiosity and hyperspirituality. Okay, it has been observed that seizures that are associated with hyperreligiosity are more likely to have a seizure onset zone in the hippocampus than in the amygdala. And so we tested whether this observation also aligns with our spirituality circuit. And indeed, the hippocampus is circumscribed within the positive functional connectivity relative to the periaqueductal gray, whereas the amygdala is not. The amygdala falls outside of that functional association zone relative to the periaqueductal gray. And so this is another category of evidence that converges with what has been observed, that seizures causing hyperreligiosity will tend to have a seizure onset zone in the hippocampus. There's been a lot of social commentary about the nature of religion, the nature of spirituality, and just as a more high-level observation, features like fear conditioning, pain inhibition, and also altruistic behavior are some of the canonical functions that have been associated with the periaqueductal gray, both in non-human animal studies as well as in human studies. And so across different sources of cultural commentary on spirituality and religion, you have observations that fear and fear conditioning are related to religious behavior. This is from the book of Proverbs, that the fear of the Lord is the beginning of wisdom. Pain, Karl Marx famously noted that religion is the opiate of the people. And then across a range of religious and spiritual traditions, you have an association of spirituality and religiosity with altruistic behavior. And so again, this is less of a scientific confirmation, but at a social observational level, I do think that it's interesting that these various aspects of stereotyped religious and spiritual behavior correspond very neatly with these canonical functions of periaqueductal gray circuit activity. Okay, so as promised, now this really is the last exploratory analysis that we did, or the last analysis, which was an exploratory analysis that we did, and it was looking at the alignment of symptom-causing lesions with our hypothesized spirituality circuit. And the goal here was to test whether brain lesions causing specific clinical outcomes preferentially align with our spirituality circuit. This is a huge part of the work that we're doing at the Center for Brain Circuit Therapeutics, is to identify causal substrates for specific clinical symptoms and for different clinical diagnoses. And so at the time that I was performing this study, we had resolved brain circuits that underlie symptoms including akinetic mutism, down this list here through Parkinsonism. And so I tested lesions from independent samples of patients whose brain lesions, again, precipitated these symptoms. The steps for this analysis were to trace the symptom-causing lesions on top of our periaqueductal gray network. And so in these 3 different rows, you can see examples of 4 out of the 29 brain lesions that cause Parkinsonism and where they're located relative to that heat map of periaqueductal gray circuit connectivity. In that second row, those are 4 out of the 50 cases for brain lesions that caused alien limb and where they're located relative to our periaqueductal gray circuit map. And in that third row, brain lesions causing delusion, 4 out of the 15 cases, and where they are located relative to our periaqueductal gray circuit heat map. The next step then was to calculate the sum total of the voxels within each lesion trace. And so again, this is what we call a network damage score. It's a quantified value of how much damage each of these brain lesions inflicted on our periaqueductal gray circuit. Then I performed an analysis of variance to test whether there was a symptom-based preferential alignment with lesions relative to our periaqueductal gray circuit. And it was a hugely significant result. In other words, that yes, it does matter what specific symptom you're looking at in terms of whether the brain lesion causing that symptom is going to align with this hypothesized spirituality circuit or not. Lastly, I looked at which specific symptom categories were driving the significant association. And in the direction of decreased spirituality and religiosity, this was being driven by lesions causing Parkinsonism. This also does correspond to a wide range of clinical reports as well as meta-analytical reports, indicating that as symptoms for Parkinson's progress, that individuals tend to have a decrease in religious or spiritual motivation. And in the direction of increased spirituality and religiosity, the greatest association was with brain lesions that cause delusions. And so if we consider the features that spiritual acceptance and delusion share, I mean, almost by definition, they're both associated with strongly fixed beliefs. And so the characteristics of these two different sets of behaviors do align. It is important to note, and I think that this is, crucial, lest we have a runaway misreporting of the implications for our findings here. But it's important to note that a shared neural substrate may be helpful for understanding features and associations, but the results shouldn't be overinterpreted. And perhaps this is more intuitive if we first consider Parkinsonism, that of course, it would be inappropriate to conclude from these results that the onset of Parkinson's is caused by a lack of religious faith. And in the opposite direction as well, it's inappropriate for us to reduce or to make a direct equivalence between spiritual belief and delusion. If you look at some of the cognitive traits and features that are associated with the negative correlations relative to the paraequidoctal gray, these include critical reasoning supported by the frontoparietal control network. And so one of the popular cultural references that I think illustrates this association between faith and reason is the movie Contact. It's an adaptation of the Carl Sagan novel. And you've got Ellie, the scientist played by Jodie Foster, who just has a really difficult time dispositionally accepting any premise or any proposition that can't be reasoned into or logically proven or materially demonstrated. And so then you have Matthew McConaughey's character who plays a spiritual pastoral figure who asks her to prove that her father loved her. And, of course, she's not able to do this. And so she somewhat reluctantly comes to accept that, okay, perhaps there are aspects to human experience and to life generally that don't cleanly fit into material proofs or logical demonstrations. I think that it's very notable and very interesting that then if you look at independent studies that are examining the neural correlates for phenomena like compassion, parental love, unconditional love, that these studies indicate peak associations right in paraequidoctal gray central circuits. Okay, so now this is where I get especially geeky, is looking at classic spirituality literature. So for example, there's a 14th century mystic text called the Cloud of Unknowing that makes what I find to be just a really stunning observation or claim on human nature. It says that all reasonable creatures have in them one principal working power, which is called a knowledgeable power, and another principal working power, which is called a loving power. And then I gave a mention to the 16th century mystic, Teresa of Avila. She makes this assertion in one of her famous texts, The Interior Castle, where she says the important thing for spiritual growth is not to think much, but to love much. And I could give you a litany of examples across different traditions of this dichotomy that's been observed by individuals who spend a lot of time, carefully contemplating and introspecting on human interiority and human nature of this interesting dichotomy between reason and between faith and love. And in fact, I teach an entire course at Harvard Divinity School where we look at some of these relationships that we can observe across spirituality literature and emerging human neuroscience. The title of the course is Neurospirituality. And then I'm so happy to say, such a well-received course. This semester I was asked to do directed readings for grad students at the Divinity School, focusing even more specifically on the intersections of mysticism and neuroscience. So we've had just a great time reading Bertrand Russell and his essays on mysticism and logic, and then looking at classic mystical texts. And if you recognize some of the psychedelic molecules there in the middle, it's been a really fun set of conversations over at the Divinity School. And then, as was mentioned in the generous introduction, this semester I'm also co-instructing a cognitive neuroscience and meditation course at Harvard College. All of that to say that I'm just delighted that there is an educational reception as well as a research reception for this union of spirituality and of neuroscience. All right, I'm gonna, just because I do want to be sure that we have time for questions and for conversations here, so I want to move a little bit quickly through the works that I have in progress. As I mentioned before, this most recent biological psychiatry paper was looking at the union of spirituality and religiosity. And so natural follow-up questions are looking at where spirituality and religiosity diverge from one another and the brain circuits that subserve those divergences. To operationalize subjective spirituality, I'm looking at trait measures of mysticism. And then to operationalize tradition-oriented religiousness, I'm looking at trait measures of fundamentalism. Example items from mysticism, this is from the Ralph Hood mysticism scale. The example items include, I've had an experience in which I felt myself to be absorbed as one with all things. I've never had an experience that seemed holy to me, that gets reverse scored. And I've had an experience that was both timeless and spaceless. For fundamentalism, example items include, whenever science and sacred scripture conflict, science must be wrong. It is more important to be a good person than to believe in God and the right religion, and that gets reverse scored. And to lead the best, most meaningful life, one must belong to the one true religion. So individuals, again, have a single value score for trait self-reports of mysticism and fundamentalism. We have a wide range of lesion locations associated with these trait measures. And using these lesion network techniques are beginning to map independent brain circuits that are associated with mysticism and fundamentalism. And then just to, again, give you a really sneak peek of where I intend to take this work, it's to then go even further, particularly in mysticism, to then look at subcomponents. So for example, one of the topics of conversation right now in mysticism associated with psychedelic interventions is whether therapeutic outcomes are related more to ego dissolution and the sense of self-loss, or to the sense of union or transpersonal identification. And these are the types of things that we'll begin probing more deeply by translating these into brain circuit-based questions. Right now, with regard to the core research program that I'm developing with Neurospirituality, I have projects in the works that are related to memory, meditation, prayer, psychedelics, and music. Of this, this sweet set of 5, memory is the one that people often say, like, how is memory related to spirituality? And it's so related is the short answer. But across philosophies and across tradition, there is a strong association between memory and between spirituality, associations with memory being the seat of wisdom. Memory is variously called one of the so-called spiritual powers of the soul, along with the intellect and the will. In Aristotle's writings on memory, he makes some very provocative speculative claims about potential influences on spiritual functions that are derived from memory. And then I think that probably these topics of meditation, prayer, psychedelics, and music may be a little bit more obviously intuitive about how they are related to spirituality. Now, the big list, this is a set of relationships between spirituality, neurospirituality, and then clinical symptoms or outcomes that is way more than I'll be able to do in my own career. And so I very, very enthusiastically would welcome collaborations. But some of the connection points that I can anticipate would be with depression and existential anxiety, life meaning and purpose, pain management, spiritual trauma, alcohol and substance misuse, religious OCD and scrupulosity, mysticism and psychedelics, again, with this recurring observation that the mystical experience is a marker and a predictor for the therapeutic outcome of a psychedelic intervention. Music medicine, nature immersion, end of life care. And then I'm, again, very happy and excited to talk with any of you about interests that you may have in this domain of clinical neurospirituality. To give you just a little bit more of a flavor of how I think about the integration of spiritual studies with hypothesis formation and then moving toward evidence-based investigations that have a clinical application to them. Work that we're doing right now at the Center for Brain Circuit Therapeutics has identified two major symptom clusters for brain circuits associated with depression. And one of my colleagues, Dr. Shan Siddiqui, has identified what we've dubbed an anxiosomatic cluster and a dysphoric cluster. And as a reader of Noche Oscura, or what's termed Dark Night, or sometimes Dark Night of the Soul, like this just jumped out at me. So in the text of Dark Night, there's this bifurcation of the types of melancholy that an individual experiences into, what is termed in the text a night of the spirit versus a night of the senses. And conceptually, these two different metaphorical nights sound so similar to what we're identifying as dysphoric or anxiosomatic clusters of symptoms associated with depression. And so within the text itself, there is this recommendation that experiences that are mystical or transcendent in nature provide remedies for this so-called night of the spirit, and that exercises that have some kind of an ascetic character to them might provide remedies for this so-called night of the senses. And so again, this is more to give you a gist and a sense of ways that I think classic spiritual texts and evidence-based sciences might be brought into conversation with one another. In maybe a bit more of a tangible way, I'm doing some work that's looking at religious OCD. As you may know, scrupulosity is a psychological disorder that's primarily characterized by pathological guilt or obsession associated with moral and religious issues that is accompanied by compulsive moral or religious observance. And it's highly distressing and it's maladaptive. Here again is one of the ways in which we need to be realistic about the fact that spiritual impulses, religious impulses, are not always adaptive. And especially in the case of scrupulosity, it can be quite debilitating for the individual. There's been tremendous work to identify brain circuit targets, both at the level of non-invasive brain stimulation, like transcranial magnetic stimulation, as well as deep brain stimulation to treat obsessive compulsive disorder. And so an empirical question is whether religious OCD or scrupulosity should respond or will respond to these same brain circuit stimulation targets, or whether we really need to be identifying a different subset of brain circuit targets to treat religious OCD through these means of TMS or DBS. And this is work that is underway in partnership with Brigham Young University in Provo, Utah, where we're using a religious distress test where highly religiously motivated students are in the scanner and are asked questions that do precipitate feelings of scrupulosity. And the goal here is to identify circuits that are associated with these feelings of religious scrupulosity and to compare those to the brain circuit targets for general OCD and see whether there is a convergence there or not. All right, stepping back for a minute away from the science of the brain and turning rather to the philosophy of brain and mind, I will say that this is an amazing intellectual moment for a pursuit like neurospirituality. There has been within modernity this really harsh and quite divisive relationship between what's termed substance monism and substance dualism. But this dichotomy is starting to give way to a broader diversity of paradigms. There's a wonderful set of books that are looking at different perspectives, whether it's panpsychist or embodied cognition perspectives. So Galileo's Error, Mind and Cosmos, I Am Not a Brain, The Embodied Mind, phenomenon of life, mind, matter, nature, mind and life, whatever happened to the soul. The main point here being that a range of thinkers from a range of perspectives are really giving us some exciting alternatives to these somewhat harsh and tired and divisive battles between, again, so-called substance monism and so-called substance dualism. And so I think that one of the things that is provocative is a notion of a sacred monism, or the idea that in order to realize, again, some sense of sacredness in life and in existence, that like that can fit into the suitcase of monism, that you know, it's a false message to say that in order for there to be a concept of sacredness, that we now have to resort to some kind of a metaphysical dualism. Okay. If you're interested in following the work that I'm doing here, you can check out my website, neuromichael.com. And I am also on social media on Twitter, where I give updates about my speaking engagements and some of the work that I'm doing. Most notably, and perhaps of interest to some of the participants here today, I was recently involved in a debate at Oxford on whether or not psychedelics can advance an understanding of human spirituality. This was such a fun event. And the video is now available online if you'd like to check out the proceedings for that debate. And then I also do have a YouTube channel, Neuromichael, where I translate some of these more technical concepts into videos and into digestible concept that I hope can be accessible to a broader popular audience. In conclusion, although there have been compelling reasons to build a wall between science and spirituality, I argue that that time has passed, and that by reintegrating health, healing, and spirituality, we're actually not doing something new, but it is a project that we're now technically equipped to pursue in a first of its kind empirical fashion. And further, I argue that brain circuit mapping and stimulation is an ideal scientific platform to support this type of a project. The vision here is one of unifying health sciences and spirituality studies for the benefit of patients. And my overarching hope is that by identifying brain circuits that are associated with diverse spiritual practices, we may eventually give clinicians a toolkit of evidence-based spiritual therapeutics that they can match to specific symptoms that their patients are experiencing. And with that, I will be very happy to receive questions from you.
Michael, that was just phenomenal. Thank you. And thank you for the passion that you bring to this and the rigor that you bring to it and the provocative questions that you really ask. I think, as you said, this is just such an interesting time in history where a lot of different cultures are coming together, and I think a lot of richness is going to come out of that. So thanks for your leadership there. So I want to start, there's a lot of questions, but one that I think you touched on at the end, and I think is maybe a question for a lot of people. You know, with your experimental work, you talked a little bit about this sort of brain-based, more materialistic model of things versus a more embodied or ecological model of consciousness and things like that. And your work, which is so experimental, almost implies that, you know, that the brain is causing these experiences, that you need to change the brain to have those experiences. And I'm wondering whether your work also touches on the converse, that having a spiritual practice creates brain plasticity. And then the question goes beyond the brain. Are there other markers in the system that are not brain? What happens to the heart in a spiritual moment? Is there a signal there that's just as valid? And one could say maybe this starts in the heart, or how people move in these embodied cognition ways, or even emergent measures of biofields. We can look at the magnetic field of the body, things like that. I know you're a neuroscientist, so that's your tool and that's where you started. But since you're part of these big discussions, I wonder if you can, there are going to be people out here saying, don't tell me my spirituality is due to my brain. And I'm
Sure.
wondering if you can address that really core concern in the context of these different questions.
Yeah, no, that's great. Certainly the last thing that I want to do is to reduce everything to just saying like, we are brains and bats. That is not at all where I think that this will go or should go. With a lot of the work that we're seeing, where we start with spiritual practices or spiritual disciplines, and then see subsequent changes in the brain, whether that's functional connectivity changes, whether that's anatomical changes, things like cortical thickness, or changes that can be discerned on DTI. Absolutely, like that is inconclusively that there is this top down, so to speak, modulation of the brain that comes from a connection to spiritual practices and spiritual disciplines. And that's thrilling. That's exciting. I mean, that increases so much complexity as well, but in a way that I think is really energizing and that I'm excited to lean into further. You're totally right that a lot of the things that I'm doing right now can be interpreted as saying that, oh, the brain is the seat of all of this. But maybe, if I can just give an analogy here to try to dispel that and create a different frame for how to interpret that. I could, take my phone and do any number of operations in it and access information from Wi-Fi and, from various locations across the world. And I could have a specific circuit in my phone that then gets broken. And then I lose that function. I lose the ability to connect to the Wi-Fi, or I lose the ability to perform any number of operations. But to say that like, oh, the entire time, the whole concept of that function was only living in that circuit would be like just such a clear misinterpretation of the facts of the matter.
Yeah.
That there could be a necessary component of that circuit in a larger function, but in our culture, we're so quick, unfortunately, to jump from necessary to sufficient, and that's just an inappropriate jump for us to make, especially when we're talking about these things that are, wisdom traditions and that are so holistic and integrative in their nature. So that's one comment there. I would say that one of the directions I'm really hoping this will go is to span quite widely a range of spiritual practices, whether that is ayahuasca ceremonies or contemplative prayer practices or, ecstatic worldly direction. I mean, to really go the gamut of the world heritage of behaviors and then do careful association mapping with not only the circuit correlations, but the effects of how those change the brain dynamically.
Super. Well, there's so many questions. I want to see if I can get to some of them. And my sense is you can talk about this next one for a couple hours.
Okay.
The question is, can you unpack a little bit of your interests in psychedelics and how those potential changes, not just in neural networks, but all the systems might interact with these observations of neural networks and phenomenology around spirituality?
Sure. Where to even begin there? There was actually we're in March now, believe it or not. I can't believe we're already in March. So in January, there was a really historic 2-day workshop that the National Institutes of Health sponsored, where they looked at some of the current work that's been done on psychedelic interventions. And I've got to tell you, the effect sizes for psychedelic interventions are just eye-popping. Studies on reductions in alcohol misuse or compulsive drug use, tobacco use. I mean, we're talking about R's of 0.8, 0.9. I mean, just huge correlations in terms of even single or short-term psychedelic intervention, and then these rapid decreases in clinical behaviors that haven't responded to other forms of intervention. And so I think that first and foremost, again, given that my primary appointment is at the medical school, I am interested in finding really powerful ways that psychedelics can be used to treat symptoms that have not responded to other types of interventions. Expanding out from there, I think that there are fantastic philosophical questions that emerge from psychedelic interventions and carefully controlled experiments with some of these substances. There's a terrific book called Sacred Knowledge, written by a psychologist down at Johns Hopkins, where he documents how themes, including God and immortality and beauty and love and wisdom, I mean, things that really are at the heart of what is revered across spiritual traditions, continually come up within psychedelically induced experiences. And just that in and of itself, I find very fascinating. Again, to summarize, I would say that first and foremost, I'm very intrigued by the clinical potency that seems to be emerging very rapidly from psychedelic interventions. And I do think that there's going to be a wide range of philosophical questions we can begin to address with them.
Super. Another rich area of interface. And I'll alert everyone that next month we have a lecture in our grand rounds on psychedelics and psychiatry by Dr. Franklin. So that's going to be really a good presentation as well. There's some questions about childhood trauma, a couple questions, and whether there's known relationships between that and people's phenotypes of being spiritual and or of course the neural basis of that. I wonder if you can just touch on that a little bit.
Yeah, no, great and really intuitive question there. There is a body of literature looking at attachment theory and the relationships between attachment and attachment trauma with spirituality. As you can imagine, there are so many factors that contribute causally to spirituality and to religiosity. And so, it's not as simple as like, oh yeah, here is now the one contributing attachment effect. But there are trends that recurringly present that there is an association such that, early attachment traumas might inhibit the experience of the expression of spirituality. These, I would say, also are some of the things that I think are going to dovetail with psychedelic therapies. When we're looking at the impacts of MDMA, of 5-HT2A receptor agonists, that there really are remarkable outcomes in terms of recovery from psychological trauma, attachment trauma. And again, I can't help but speculate that this, at some neurobiological level at least, is related to why we tend to see an increased trait openness or an increased response of mystical experience or spiritual openness following psychedelic experience.
Super, really interesting response. There's some clinical questions. You talked a lot about psychiatric disorders. There's a question here about pain and pain care and the value of spirituality and pain care. And a very practical question in terms of, in large databases, are there some simple or validated patient-reported outcomes that can be folded into everyday care for patients with pain, so that we can start to assemble a better sense of what's the interdependence of pain in people's spiritual experiences, whether, as you're saying before, adopting practices can impact pain, or whether there are ways that pain influence that give us ways of breaking through that pain cycle.
Yeah, great question here. So looking at the brain circuit correspondences in our data sets between the spirituality circuit and between brain lesions that are associated with pain, they do align in the direction that we would predict that some kind of spiritual stimulus ought to decrease pain overall. Independent from our work, there are reports in the literature of different spiritual practices that do have an effect on reducing pain. One of the grant proposals that I actually have out right now is to combine music interventions with spiritual interventions. So incidentally, there's also empirical evidence that music interventions can help to reduce pain. And so, it's a little bit, of kind of a simple equation here, but okay, if music can reduce pain, if spirituality can reduce pain, like what if we combine that? What if we have both a spiritual and a music cue or, intervention? Could that then boost these pain reducing effects? And so again, both at the level of brain circuit associations in our data sets in our hands, as well as behavioral data, I would say check out on Google Scholar, spirituality, pain management, and just explore some of the literature out there because there is an evidential basis for that association.
I'll ask one more quick question and then we'll do some comments to close up. But since you talked about music and other modalities, one modality, if you can call it that, that's becoming quite popular is exposure to nature and people's experiences in nature in relation to it. And just recently, our Osher Center has made one of our priorities to look at the integration between integrative medicine and planetary health. And we believe that how people perceive nature is going to impact how we interact with it and serve as stewards. And so I'm wondering what your thoughts are in terms of the research on nature exposure, whether they map out into some of these areas, and whether in the long run, I'm really curious whether theistic concepts of spiritual being versus more less anthropomorphic and nature-oriented senses of being connected to something might map out differently or similarly or have different effects on people.
Yeah, really interesting questions there. So let's break that down a little bit. So first, again, in already published literature, there's an indication that nature immersion has a wide range of both psychological and physical benefits. And this seems to be such a salient effect that even virtual nature immersion, so having people, watch nature videos on a digital screen, can have boosts in physical and psychological measures of well-being. So, I mean, as a total side commentary, I'm like, why don't we have a nature channel playing on the TV in every patient room at the hospital? It seems like
they're doing that.
Oh, good. Okay, I'm so
and
relieved.
even at Brigham, the lone cardiovascular center has done that, and there's research going on just showing playing these in hospital settings affects well-being.
I'm so glad to hear that. Okay, thanks for informing me on that.
Yeah, 1 minute to wrap this up.
Okay, so then I would say that to jump into your question about theistic versus non-theistic, that the degree to which we can actually disrupt that binary in thinking and create some kind of a nature-based spiritual paradigm or philosophical paradigm that can invite in people from either a non-theistic or a theistic point of view, that there would be personal as well as, I do predict, social level advantages. If you have individuals who recognize that even the plant world is an intelligent sphere. I mean, man, I'm going to throw out some terms here that are going to make me sound like a crackpot hippie, but like there's good emerging data to support arguments that plants even have intelligence. Again, I don't have time to justify that right now, but
my training's in evolutionary biology of plants, so I'm with you.
There's
a lot of intelligence there.
The difference between recognizing our ecosystems as intelligent life forms of which we are part, how could that not precipitate a huge shift in the way that we're relating and interacting with our planet and with ecological systems?
Super. Well, I just want to say thank you for such an engaging and provocative and really rigorous presentation. So thank you for taking time for putting that together and for all the work you're doing. Just a couple quick announcements to our community. First, we hope that you'll join us next month on April 5th. And this is going to be an extension of this discussion. As I mentioned, Dr. Franklin King, who's a psychiatrist at Mass General Hospital, will be talking about the psychedelic renaissance in psychiatry. So that'll be another interesting talk. And you can learn more about these programs. You can view the talk today and all our other recorded grand rounds, and even make a philanthropic donation to support our Osher Center at our website, oshercenter.org. So thank you again Michael, and thank you to our audience for participating today. And I hope to see you all next month.
Thank you so much. Take care.